So we switch now to another center, okay.
Welcome,
Good afternoon,
Dr.
Dr.
Keshava
Srinivas
and
Kumar.
Gopi. Here,
Yeah.
Dr. Surya Prakash Rao, Dr. Kapadi,
Sir.
Anand Nyandas, and Dr. Farinek on the dais.
So good afternoon from the
Sir,
Convention Center from Hyderabad. So go ahead. We are really, we would like to see
Yes,
your
sir.
case. And
Good afternoon, sir. And on behalf of myself and on my left side is Dr. Gopi, Dr. Harsha, and our technical team. We thank Dr. Srinivas Kumar for this opportunity. We have a 75-year-old male. Can you show the slide? Is a diabetic for 30 years, hypertensive for 5 years, CVA 5 years back. A known case of CKD, creatinine clearance is 32 ml. This thing presented with history of angina. CAG was done. He has a left main plus TVD. We will show the thing. Syntax score was 29. Syntax 2 score was 40. Euro score 2 was 2.1 and STS score was 1.1. Can you show the angiograms? Angiogram, Dr. Gopi will discuss the angiogram.
So this was this patient angiogram shows there was a tight stenosis in the left main. I had a very long left main, and if you see that after the stenosis there appeared to be slightly like an aneurysmal outpouching as such. And then if you see a grossly calcified proximal circumflex artery with almost subtotal occlusion. He had a total occlusion of the right coronary artery. Can you show us the right, please?
Next angio. No, angio.
Yeah. This was the right coronary artery which showed a total occlusion. So our plan was that we will do an angioplasty for the left circumflex artery and for the left main. For the circumflex, we thought we will leave it for now.
Minus.
Now, in the meanwhile, while we were waiting, what we have done is, we have done an initial IVUS of the left main. We will show you the IVUS of the left main.
Can you see the IVUS? Show the IVUS, please. IVUS. We are not able to see the IVUS
at the
there.
moment we don't see IVUS.
Yeah.
Okay,
you
now
can
we
play.
see.
You can see the IVUS, please.
Yeah. The IVUS shows a circumferential calcium starting in the LAD. The lumen area is quite good over there.
A lot of circular calcium, so probably will be good case for a large
360 degrees
shockwave
calcium.
balloon.
But at that place, the lumen was very good, so we were not really planning to address that segment. That is a proximal LAD. And as we come proximal, further in the still the LAD. This is the first run, no? Yeah. We are still in the LAD.
Yeah,
that is a circumflex that is coming over there. Now,
left main lumen was quite good, though that there is a 360 degrees calcium. Yeah. Here you see the tight portion.
This will be critical.
The minimum area was coming around 4 millimeters square.
And then
here you see, freeze this point. Here you can see that, go back a little bit on the left side. Yeah, here you can see the outpoaching what you used to see on the angiogram. There you can see, yeah. This is looks like a pseudoaneurysm or a outpoaching or ectasia or what. The diameter at this place was, can you show the measurement? 5.1. Yeah, play this angiogram further, IVUS further. Now again you see another tight portion. Yeah, the minimum area was tight at this point was 4 millimeters square. Left main distally was 4, proximally was around, maximum area was around 5. at that aneurysmal segment. So we'll go to the angiogram.
Yeah.
At, this one we should
Yeah.
discuss.
This is the one.
Shows crusade.
Yeah. So what we did is, we have already crossed the circumflex and done the angioplasty for the circumflex.
So this was a crusade.
Yeah.
This was a crusade
Because
catheter.
it was a very tight lesion and calcification.
I think he took a double lumen catheter.
We were sure that we would not get.
Yeah,
We took a double lumen catheter so that we could get support to enter into the left circumflex artery. We used a crusade catheter. I used a Scion blue actually to cross the lesion. Surprisingly, the lesion was crossed quite easily. Next, the lesion was crossed quite easily, and following that, we took a 2 mm balloon and we dilated it. Following that, we used we tried a Opian 2.5, but we were not able to cross the lesion.
IVUS didn't go.
Then we thought we'd see the IVUS and see what is happening there, but then we could not take an IVUS into the circumflex artery.
Did you try to use guideliner to improve the backup?
No.
Actually, we didn't do that because one is I was concerned a little bit about the lesion in the left main, and that outpouching. I thought I will manage without the IVUS, and
then my recommendation will be
Then
to
after that
fix
we
the
took a
proximal
2.7
left main lesion and then to continue the case for CERC. Okay, but you now...
No, sir, but actually we
you
have
could
progressed. Yeah, we took a 2.75 new balloon, and then we prepared the bed. Following that, we took next.
That was a 2.
Yeah. So at
2
this,
OPM.
then we also took a 2 OPN and went up to 30 atmospheres just to crack the calcium. Next. Yeah. Next, we took a 2.5 by 22 onyx stent.
So you
We
ju-
were able to track it reasonably easily into the circumflex artery.
so there
And
was
if you
no
notice that in the
balloon-
RAO caudal, we are not really. Sorry?
So there was no balloon in LAD
This-
if you perform this?
No, there is
Also
no balloon.
CERC stenting?
No, there was no balloon in the.
We took
No, so we thought we'll just keep it exactly
There was
There's
a
usually
short of the
always some
ostium.
kind
PA
of
cranial
protrusion.
shot here.
And now you
Yeah,
have
here
dissection in the
we
left
got this
main.
better shot in this view. PA.
Yeah, so, but patient is quite stable, and we were quite happy with this position, and we deployed the stent in the left circumflex artery. Next.
Next.
Yeah. So this is we post dilated with a 2.75 balloon, and
Yeah, this is at 20 atmosphere, 275, and this is the result at we'll taking now. We'll take a image.
okay.
So fine, so we have
What do
now
you feel
quite
the
good flow
image
in CERC, so the CERC is fixed at
circumflex?
the moment, and now focus your attention to the left main.
Left main.
Yeah,
So
our plan is to
You have to
do a
cover from the
dilatation
ostial
with a,
left
maybe
main,
a 3 or
long
3.5
stent.
mm balloon from the ostial left main, but we will stay short of the bifurcation. That was the plan.
Yeah, you need now...
Yeah.
Does the
because
panel agree with us?
You have seen any plaque just before the circumflex?
I was
in the left main?
distal.
Just take
No,
a long
it's calcific, but the
3.5
lumen is quite
balloon
good.
and C balloon predilate, and then go ahead with
Give me a
4.5
3.5
stent.
3.5, 18 or
Generally,
20,
most of the time we
50.
see ostiums either separately involved or a shaft to distal bifurcation. This is little unusual, good for them to do the
That's
case.
first time I'm seeing that. Either
Yeah.
you have a ostium
Yeah.
or from the distal main to the
Yeah.
shaft.
That's what
But
it's created for you to do
We are
live
quite
case little
lucky in
more
that way.
easily. But
So
what
it's-
Farag was telling was, sir, basically when you're putting a ostial location of LCX, it's better to have some, because you're not wanting to intervene there, you didn't put, I think.
Balloon.
Generally, if you have to avoid too much
Yeah,
protrusion,
it
what
was
is
actually a, yeah.
Yeah, yeah. ठीक है.
Then if you have a flap at that
Yeah,
point,
actually you
if
show the
distal
PA
part of the
cranial
stent, put
original
another
angiogram.
stent,
Go
so two
forward.
overlaps at the circumflex, the outcomes will not be good.
Yeah,
in
avoid
follow-up.
overlapping at the branch point.
So
Yeah,
what is your next
freeze
step?
this
To
osteum of the
take a
circ-
larger NC balloon and
We are going to
credulate
take a
the
3.5, we'll take a 3.5 balloon, dilate the
Yes.
left main, and then we'll stent the left main.
Yeah.
If you see in this view, the actually circumflex is perpendicular. We thought that actually PA cranial is not a good view to deploy the circ, but in this view, we were quite sure.
You have a small stump-like thing also, that's why you could get away. That's okay.
Yeah, exactly.
Yeah,
get
that's
away.
that is why we thought we will.
Actually, we took multiple shots for in LAO caudal, PA caudal. We are not able to identify the origin of the circ very well, but this was the view which showed
Okay, I
quite
think
easily the perpendicular.
Yeah, yeah.
so go
origin.
ahead with predilatation because we would like to see
Yeah, we are
the
taking
Yeah,
left main stenting in your case, and then we switch to
yeah,
other
Dr.
cath lab.
Pratap's case there. Yeah, we have taken a 3.5/15 NC balloon.
Show me where we are. I think that should be okay. I think.
Further, little
Okay, no?
further, little
It's okay,
further.
no? Sure. Yeah. Okay.
Are you
3.5
not
by
modifying
15.
with cutting or scoring balloon, Dr. Keshava?
No, so the
NC balloon, regular NC.
Because
Yes,
you
sir,
have
we kept
documented
it,
calcium and all these.
And
Yeah, circumferential calcium was
Yeah.
seen in
but
IVS.
at the area where there was maximum narrowing, there didn't appear to be too much of
There was
calcium.
more
So we thought we will more of
fibro-
fibrous. So we thought we could manage with the NC balloon itself.
can you show the IVAS image? Sine? Image
Small
looks
ulceration on the
quite
top of
good
left main.
expansion as of now.
Yeah,
Yeah.
that's what.
You
So
have to
we are
take
actually
now
taking a
a
4
bit
by 26 milli.
longer stand and
We are taking a
minimum,
4 mm stent because, yeah,
426 we are planning.
minimum 4.0,
26
maybe
sufficient?
4.5.
Very long left
26.
main.
Probably
yeah,
4.5.
we are taking a 4 mm stent because most areas it is, we thought in the other areas 4.5 may be too large near the ostium and the distally. Only where that ulcerated plaque is, it was about 5. So we'll take a 4 and then we will go in with a 5 mm balloon at that particular spot.
And
Left
then
main,
we'll do
you
the
got
final
4.7,
IVAS
4.9 on IVAS, sir.
That is only at that one particular spot where there was a, the aneurysm. The rest of the areas was about 4.1,
Anyway,
4.2.
luckily
it
this
was.
Onyx 4 mm can go up to...
Yeah, I think 4.5 and then you can
Yeah,
take
can-
5.0
Yes.
for 5.5 balloon.
This interesting
Keep
study
some-
of
keep a
Rolex
28
was
mm
done
ready,
with
a
this
stent if this was-
title Rolex, it looks very interesting, but the results were quite good.
Can you
So
come
now-
to the
So we are taking a 4 by 26
more RAO? Come out of
Onyx.
Just suited for
I
him.
think this is definitely good choice and go to LAO cranial to have now.
We'll go to LAO cranial
best
now.
view
PA
to-
cranial, P-
LAO
cranial.
cranial is the best view
osteum and
if
LAO
you
cranial.
Yeah,
try to
we are doing that.
position
Yeah.
for positioning of the
Guider
stent
engage.
in the left main.
Osteum coverage. Cranial is the best to see the osteal coverage.
So we'll
Yeah.
give you an injection here now.
Correct.
Because stent starts a
Come to PA
little
cranial.
distal to the marker
that
in this, you should be a
magnify?
little more careful.
Yeah. So
This
Maybe-
position is perfect for Zines.
yeah, but
Yeah,
I think it
should
looks
only.
perfect.
Just okay.
But should we take out the balloon circumflex first?
Yeah.
I will take out the circumflex wire. Is that okay? What do you like? You all agree with that?
That's perfect.
Yeah,
Yeah,
yeah.
remove.
Anyway, you're not doing anything there now. You're ending proximal to it.
This
It's a
is the
lady,
LED, sorry. Oh, we took it on there. Oh, we took
It's
it
a
on
wrong
the-
wire.
Okay.
That we should be careful.
Okay. Yeah, I think we have taken it.
No,
Sorry, we have taken it on the
properly and remove
circumflex
the correct
wire
wire,
itself.
sir. Otherwise, you will land in trouble.
Important
Yeah,
again, you have
otherwise
to
we'll
check
take it.
the
We'll take
position
the
in the lower cranial after
No, no.
removing this wire.
After removing the wire, again we should check.
Yeah, we will.
Why is it?
Circ wire. Circ
They're
wire.
I think
That's
we
why
took
they
it on the
removed it.
circumflex wire. We will go back onto the LED wire.
But still, they are not wanting to go into bifurcation anyway.
Yeah. So what's happened?
They're removing the stent and they're removing the wire, they're changing.
No,
to
we're just
LED.
changing it. We're going it back into the LED wire.
Okay, it was so. Okay, yeah, it can happen.
Pressure.
Good position. Yeah.
Yeah. Arrival code.
It means the same.
Yeah, anyway, you're not
Actually,
crossing the
they're
belt.
not into the LED, so
Yeah, but just, yeah.
Yeah, levocranial.
Cranial now. Once you get the position, we change it. And give us now.
Okay. This view.
So
this
now you
PA
can
cranial.
remove the wire from circ.
Yeah.
Yeah, we will do the, we are removing the circumflex
And
wire
maybe
now.
a half millimeter
Yes.
back
Can
with the
injection?
stand to the aorta, into the aorta. You need,
We will go back to the cranial, take one more view.
Cine.
yeah, we have impression there is some protrusion of your
Come
circ.
come back a millimeter about this.
You
come
need
back. You have to come back
definitely
few
to go back,
millimeters.
Yeah.
and
Yeah,
because other hands you will touch the circ stand.
The circum. Guide pull and
And maybe 18 millimeters or 20 millimeters will be safer, but
yeah.
this is crucial point because you have to avoid.
Freeze.
Yeah, I think it's not so
Yeah.
bad.
Avoided the circ.
But that
So
is,
come to the
but
other
is that
view.
too much? I think it's too much.
No,
Too
that's
much
fine.
in aorta.
Yeah.
You can open
Is
stand.
good actual.
That's fine.
Check the other view. Other view. Cranial. Cranial. Arrival cranial. More.
Yeah.
Center.
Center.
Yeah. Mag. Think it's okay or is it too much hanging?
We do have a little bit of distance again. We can push.
Push.
The stent starts anyway just distal to marker. I think one strut more it is. You can't
Yeah.
towards
Yeah. Just go to the
complete
cranial
coverage
again.
rather than missing it. Because again, if you miss it, it's a big problem.
Center.
Yeah.
Yes, correctly.
Magnify. Freeze.
You could go ahead.
Yeah. I think that should be okay. I think. Yeah.
That's okay. Even distally
Yeah,
also
yeah,
is fine
And
proximally.
even if you open the
Yeah.
stand,
Yeah.
push a bit
11.
because sometimes
What's the nominal?
11.
11. Yeah.
sometimes onyx could jump into the aorta.
Pull and inflate again. We'll take it out.
You're going to just pull the balloon back and just flare up the edges.
And then probably flare it before you get it totally out.
I think this is very important point
Yeah, that's
to
what we're
remove
going
the
to do.
balloon a
We're going to
bit.
do that. Yeah.
Don't touch the
Yeah.
stand struts with the guiding. This is try to avoid this.
Yeah.
And now you can go up to 20 atmospheres.
12.
It come back? Can come back a little more also.
Yeah. We did come back. Yeah. Save the floor. Save that
And the
floor.
guide was moving, balloon didn't.
Okay. So now we are. No, the balloon moved. I think.
Balloon
Balloon
didn't
is
move,
in
so
the
only
aorta.
guide is moving. Be careful to get it. Now we got it
Yeah.
out. Can give flare now. To get removed. Okay. Take.
Once more now, but then it is. No, it's. I think we have come out too much now.
Pull
Yeah,
it out.
go ahead now.
You can pull it out. Yeah.
Yeah.
Go up.
Yeah.
Not too much. It's too much.
20.
18.
Yeah.
I think maybe check the flow and then we can decide. You definitely need a larger NC balloon to postulate. So probably for distal part 4.5
5.
and for proximal
five,
part
five,
minimum
4.5,
4.0. 5.0.
12.
Nowadays, that's why we started post-dilating, then doing imaging. Anyway, most of the times it ends up with some malapposition. So we
Yeah, it
direct.
looks very nice. Okay, so guys, you can
Let's go
go
the
just
other
with postulatation and imaging, and we go now back to the
Yeah.
other cath lab to see how colleagues approach distal left main with Dicky Crush. Can we switch to other cath lab, please?
Yeah, we are back with you,
Ask
sir.
them to show that camera IVAS, no?
Hello, yeah, hi. Welcome back.
Show the
Now, while you had gone to the other lab, we have done post dilatation with a 5 by 15 balloon,
5 by 10, no?
5 by 10, sorry, 12. Distally, we went up to about short of the nominal, about 10 we went to. In the mid part, we went up to 12, and again, proximal part, we went up to about 10 to 11, because that was based on the size of the IVAS.
Okay, then show the next shot.
Now, after that, we have done an IVAS run, and we will show you the IVAS run now. Show.
Beginning, from the beginning.
Let it run? Yeah. So this is from the proximal LAD we are starting.
A lot of calcium, but lumen is still nice.
Yeah.
That's the
Yeah,
place
We
of
see,
circumflex
yeah,
ostium.
the
This is a
circumflex
Not much of
ostium
protrusion.
looks to be good. Not
Yeah.
much of protrusion of the stent into the left main.
This
And
is
we
the
have-
stent
yeah.
starting.
Ajay, I think the angulation
this
you
one.
thought it is
Can you
distorted,
please and
it's
go to
tend
the
to rotate.
LAD distal?
Yeah.
Yeah, go a little bit. Here the LA distal left main, small segment, which you are not covered. The lumen is quite good. There is no dissection, nothing, no edge dissection. Play this, please. Now the stent is coming. Distal area, stent area was coming it as
17.
17 millimeters, 13 millimeter square.
millimeters.
Play. And the entire stent appeared to be well expanded. There is no small opposition. And show the other mid area. That area, that what is the second one you have saved? Click on that area. This area was around 17 millimeter square. And ostium, actually the stent was protruding almost around 1 to 2 millimeters into the other thing. Ostium was around 12.77, and this was quite well expanded area. Here you see 1 or 2 struts projecting into the play this thing, and now we are taking one final shot.
Very good result, very large areas.
We'll do an injection.
Yeah,
Yeah,
angiographically
excellent.
looks quite good.
Good result.
So
Nicely expanded
congratulations,
stent.
dear colleagues. You have
cranial.
done very good job. I was guided PCI, and I think it was really a difficult approach, especially with the circ. But you showed us here live how to manage this, and you achieved a really excellent result for the patients. So from our point of view here, congratulations to you and your team, and see you next time.
Thank
Thank
you very much.
Thank you.
Yeah,
Keshav.
congratulations,
Thank
Keshav
you.
sir and Gopi.
Thank you.
Anything, your final words you
Same,
want to
same.
say? A big round of applause from the hall for all of you. And thank you for doing an excellent job.
Thank you, sir. Thank you. And
Yeah,
on
I
behalf
just
of
wanted, I was telling
our
Pratap
team
also, it so
and
happened
all our
that,
technicians.
yeah, thank you. It so happened that you did IVAS guided proximal and shaft left main. They did OCT guided bifurcation left main. Both results came out well. Thank you. Thanks for great demonstration.
Yeah, before you go, we would just like to introduce some other members of our team. We have Reddy, who is the technician, Santosh, Dr. Lydia, and in the IVAS we have Rajesh. So we would like to thank all of them for making it possible on the Sunday. Thank you very much.
Thank you. Thank you, sir.